Hi, this is Nursinga, and you're watching Cirrhosis and Liver Cancer. This is a continuation of our discussion, Key Concepts in Chronic Liver Disease. Cirrhosis is the end stage of many chronic liver diseases, including alcoholism, which causes Lennox cirrhosis, chronic hepatitis, fatty liver disease, which is also referred to as non-alcoholic steatohepatitis, biliary atresia, hemophilia, and cystic fibrosis. Damage to the hepatic cells is irreversible. The cellular destruction leads to fibrosis and scarring, the formation of nodules with this fibrous tissue, and impaired blood flow that can also lead to tissue necrosis. There is no really cure other than a liver transplant, so treatment is largely palliative and based on the symptoms that the patient is having. The clinical presentation of cirrhosis includes ascites, portal hypertension, esophageal varices, hepatic encephalopathy, coagulopathy, hepatorenal syndrome with loss of kidney function, and spontaneous bacterial peritonitis. As the liver tissue is replaced with nodules and fibrotic tissue, it creates pressure on the portal veins, leading to dilated or varicose vessels in the esophagus, the abdomen, and the rectum. The spleen is enlarged, called splenomegaly, and this causes thrombocytopenia to occur, so the patient is at risk for bleeding. In the abdomen and the esophagus, dilation of the vessels leads to esophageal varices, which can cause life-threatening hematemesis and melanous stool. In the stomach, peptic ulcers can form. A GI bleed in the intestines can cause maroon stool. Superficial vessels in the abdomen that are dilated are called caput medusae. And in the rectum, we get hemorrhoids that can bleed and cause bright red blood per rectum. This is a picture of esophageal varices. It's important that you monitor for bleeding. If the patient is coughing up blood or has bright red blood or dark blood in their stool, black tarry stools, restlessness, anxiety, thirst, tachycardia, tachypnea, pale, cool, clammy skin, hypotension, delayed cap refill, or metabolic acidosis, those are all signs of shock. Esophageal varices can be treated with banding or sclerotherapy. Beta blockers can help decrease the portal hypertension, and fluid and sodium management also can help decrease the overall engorgement. There is a device called a Stenson-Blakemore tube. This is not ideal. If a person is actively bleeding from an esophageal varice, we prefer to use something like octreotide that decreases portal blood flow and therefore decreases the bleeding until a surgeon can actually go in and cauterize or close the area that's bleeding. A Stenson-Blakemore tube is a large kind of balloon device that's inserted into the esophagus and inflated to put direct external pressure on the area that's bleeding. However, the risk of rebleeding is something like 80% as soon as it's deflated, so it's really a very temporary measure, and the blood can go up and into the airway. The tube itself can migrate up and occlude the airway, and there's a very high complication rate, so it's really not used very much in practice anymore. Ascites occurs because the liver is no longer making adequate amounts of albumin, and the albumin that is in the bloodstream is being forced out with the plasma into the interstitial spaces. And so we get a fluid collection in the peritoneal cavity of that vascular plasma that's very protein rich, and we have low albumin in the bloodstream. So the pull for the fluid is towards the protein, which is sitting in the peritoneal cavity. This becomes a big breeding ground for infection. They can develop a spontaneous bacterial peritonitis, and it can also progress to pleural effusion, so it can cross the diaphragm and go up and occur in the pleural cavity. If the volume is greater than 500 milliliters, it can cause an increase in abdominal girth, as well as abdominal pain and bloating. Complications in the management of ascites include problems with fluid balance and infection, as well as respiratory problems. So it's important that you monitor the fluid balance, INOs, daily weights, and measure the abdominal girth. For respiratory status, if the person appears to have difficulty breathing, you want to elevate the head of the bed to 60 degrees to decrease the amount of pressure that's on the diaphragm, and monitor for signs and symptoms of infection. You restrict sodium because water follows salt, so if you increase sodium, you're going to increase fluid retention. And then utilize diuretics to remove fluid. The TIPS shunt, as demonstrated or pictured here, can bypass the portal circulation to improve blood flow and decrease ascites. And then there's a paracentesis. So we've restricted sodium to less than 2 grams a day. We've used diuretics to increase salt and water losses. We've done the transjugular intrahepatic portosystemic shunt to decrease portal hypertension and pressures and to decrease the ascites. And if we still have excess fluid or difficulty breathing inside the abdomen, then we can do this paracentesis. And this is where we remove fluid from the abdominal space. Normal fluid is clear to yellow, but it may turn kind of a brownish color with high or elevated bilirubin levels. Often liters of fluid are removed, so you need to monitor vital signs really closely because there may be large fluid shifts that could cause significant hypotension. So frequent monitoring of vital signs and then those other signs and symptoms of hypotension. So, pale, cool, clammy skin, agitation, anxiety, restlessness, tachycardia, tachypnea, and obviously hypotension would all be included on the list. Spontaneous bacterial peritonitis can occur when the gut flora infects the peritoneal fluid. And then, just like you would expect with an infection, the patient has a fever. It's painful, so they have abdominal pain. You see hemodynamic changes. They can become septic, and they also can develop encephalopathy from this. A paracentesis is performed to obtain and culture the acidic fluid. So we'll do a culture and sensitivity and start antibiotics, oftentimes broad spectrum first, and then making sure that we're delivering an antibiotic that's appropriate for whatever we grow out. Hepatic encephalopathy can occur when the flora in the gut produce ammonia and the liver can't adequately detoxify the blood, so we end up with increased ammonia and toxins in the bloodstream. Increased ammonia causes confusion, motor neurodisturbances, and if untreated, seizures, coma, and death. There are kind of 4 stages of encephalopathy. In the first stage, there's just kind of this general confusion, slurred speech, some tremors, lethargy, even a sense of euphoria and a reversal of day-night sleep patterns. Asteriskics is the flapping of the hands, which is also referred to sometimes as the liver flap, but they can't hold their hands still. So there's always kind of this tremor or flap of the hands. Impaired writing, impaired decision-making, poor coordination. In stage 2 encephalopathy, you start to see some CNS depression, increased drowsiness, disorientation, inappropriate behavior, some mood swings and agitation, as well as the asteriskics continues. And then you start to get this factor hepaticus, where you get this sweet fecal smell of the breath. In stage 3, the person has severe confusion. They become difficult to awaken, slurred speech. The asteriskics continues, including an increase in deep tendon reflexes, and start to develop like this rigidness in the extremities. And in stage 4, the patient will go into a coma and become non-responsive to painful stimulus. Care of the patient with hepatic encephalopathy really has to be focused on safety. Because they're at risk for seizures, you're going to want to use seizure precautions and really make sure that you're maximizing environmental safety controls. Avoid protein overload because they can't break it down, so small frequent meals are going to be important. Also, don't overload them with fat. Decrease the bacterial or gut flora production of ammonia by using drugs like lactulose and neomycin. Treatment really is aimed at improving mental status because ammonia causes confusion and impaired mental status, which increases the risk of injury. Correct any fluid or electrolyte imbalances. Lactulose causes diarrhea, which is going to increase potassium losses, and it could also increase fluid and sodium losses. So it's important that you monitor potassium really carefully. The patient should probably be on a cardiac monitor if you're worried about potassium. Supplement vitamin A, B complex, vitamin C, vitamin K, and folate. So we're looking at our fat-soluble vitamins, our B complex vitamins, and folic acid as well for health. Coagulopathy occurs because not only is the liver responsible for the clotting factors itself, but the spleen is injured and can't make platelets. So you notice that where everything else is increased, albumin is decreased, platelets are decreased, and the PT, INR, and the PTT are all prolonged. This means that the patient is at high risk for hemorrhage, and patients who have cirrhosis are also at risk for developing DIC. If you recognize that your patient who has cirrhosis is bleeding, it's important to recognize that bleeding itself and then whether or not they're in shock. Control any obvious bleeding with direct pressure, pressure bandage, tourniquet if it's a significant wound. Report the findings and be prepared to administer vitamin K, FFP, or even blood. Hepatorenal syndrome occurs when there's impaired renal perfusion, and it creates a rapid deterioration of kidney function. The patient may have normal to decreased urine output and elevated BUN and creatinine. Oliguria, remember, is classified as urine output less than 500 milliliters in 24 hours or less than 30 milliliters per hour. Anuria is when you have less than 5 milliliters per hour. The mortality rate associated with hepatorenal syndrome is incredibly high, and the only treatment for this is a liver transplant to restore adequate blood flow. The medical management for your patient with cirrhosis overall is to monitor your lab values. So remember, elevated pretty much everything except for platelets and albumin, and your PT, PTT are going to be prolonged. CAT scan, EGD, ERCP are all tests used to evaluate. And then liver biopsy. So a liver biopsy, you can see here they go in through the intercostal margins and they take a sample from the liver. The problem is that we have no clotting factors, and the liver is a highly vascular organ. So this patient is going to be not only at risk for infection because they just put a hole in their skin, but they're going to be really high risk for bleeding. So monitor for bleeding. They need to be on bed rest, and typically there is pressure to the biopsy site after the procedure. If the patient does undergo a liver transplant, there are different techniques that could be used. So there's just a conventional like whole cadaver liver versus a piggyback technique, and that's basically depending on how they reattach the blood vessels. They can split the liver and they can give part to an adult and part to a pediatric patient, or they can do a living donor transplantation, and it depends on whether the right or the left lobe and kind of how they're taking it apart here. A patient can regenerate a significant portion of the liver. So if you give someone the right lobe of your liver, you can regenerate that. So again, signs and symptoms of rejection include fever, right upper quadrant pain, tachycardia, change in bile drainage, and jaundice. And these are typically seen within the first 10 days of transplant. So we use those anti-rejection drugs to prevent rejection, but they make them very high risk for infection. So just kind of to recap, they're at risk for injury, bleeding related to impaired coagulation. So look at their vital signs, the IV sites, the gums, the skin. They're at risk for fluid volume excess and fluid volume deficit. So monitor weight, abdominal girth, INO, edema, and respiratory status. They have altered nutrition less than body requirements, so we have to supplement the diet specifically with those vitamins. Restrict sodium, water is appropriate, and protein. They're at risk for impaired gas exchange related to ascites because they can't take a deep breath. Make sure you elevate the head of the bed. They have impaired skin integrity related to edema and pruritus. And when you itch, you take off that top layer of the skin, creating open areas that are portals of entry for infection. Fluid balance, positioning, offloading, and turning schedule are going to be critical, as well as toileting or whatever else you need to do to maintain good skin integrity. And then they're at risk for activity intolerance, so you need to schedule rest periods. It's important to remember that although cirrhosis is a problem with the liver, it impacts nearly every single organ in the body. Liver cancer occurs kind of as an end stage of cirrhosis or an end stage of hepatitis from heavy alcohol use, autoimmune disorders, hemochromatosis, obesity with fatty liver, also referred to as NASH, the non-alcoholic steatohepatitis, and diabetes. It can be a primary liver cancer or it can be a metastasis from colorectal cancer. It's often very insidious, related to underlying disease and the location of the liver. So oftentimes we never even know that it's there. The prognosis is usually fatal within 6 to 12 months of diagnosis, and treatment can be hepatic arterial infusion of chemotherapy, radiation, transcatheter arterial chemoembolization, radiofrequency ablation, cryotherapy, surgical resection, which is usually just palliative, or liver transplant. You see here, this is the transcatheter arterial chemoembolization. So they've inserted a catheter into the hepatic artery. And then these are all the little embolization particles here that they're injecting in. These go down and cause emboli or block off blood flow to the tumor at the base of the vessel. And what this does is it shuts off the blood supply, or kind of nutrient food chain, if you will, to the tumor, causing it to shrink and die, ideally. Remember that tumors are usually highly vascular. Many of them have properties where they can create or maintain or enlarge their own blood vessels. So oftentimes this can be fairly effective. Again, this oftentimes is life-ending. The nursing management of hepatocellular carcinoma really focuses on pain management, palliative care, treat the symptoms, assist with teaching, learning, and coping, and then provide really dignified end-of-life care. So to recap, our liver stores blood, it makes clotting factors, it breaks down red blood cells and bilirubin, it metabolizes foods and wastes, it stores those fat-soluble vitamins and iron. When it does not function properly, we're at risk for bleeding, we're at risk for injury related to confusion, we're at risk for fluid and electrolyte imbalances, and at risk for nutritional deficits. Thanks for watching.